So good afternoon or good morning, depending on where you're watching from. My name is Dr. Samir Sinha. I'm the Director of Health Policy Research at the National Institute on Aging. I'm also a geriatrician and a clinician scientist based in Toronto and a professor of family and community medicine and medicine at the University of Toronto. And you're here today to join me and my colleagues for our Shingles Awareness Week webinar. So I'm just advancing our slides here. So I just want to welcome everyone and just let everyone know that all audience members' microphones have been muted. So if you have any questions for our speakers, myself or Dr. Brown, please use the Q&A box at the bottom of your screen. If you have any technical issues, please let us know through the chat box. And again, thank you very much for joining us. We're also recording this webinar, and so that anyone who wasn't able to attend today is able to watch it, or anybody who wants to watch it again is welcome to do so as well. Just to begin, I'd like to do a land acknowledgement because the National Institute on Aging is based in Toronto, which is in the Dish with One Spoon territory. The Dish with One Spoon is a treaty between the Anishinaabe, the Mississaugas, and the Haudenosaunee that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans and all newcomers, have been invited into this treaty in the spirit of peace, friendship, and respect. So as I mentioned, for this webinar, I'm joined again by one of our favorite colleagues, Dr. Vivien Brown. For those of you who don't know Dr. Brown, she is a family physician based in Toronto. She's also an author, and she's also an assistant professor of family and community medicine at the University of Toronto. And so I'm really thrilled to have Vivien here so that we can present you some information about shingles in the form of a few slides. And then we're going to be here to answer some questions as well that you can generate for us. So if you're any questions that are coming up during our presentation, feel free to put those in the Q&A box. And any technical issues, please use the chat as well. So just to start off, right, when we think about shingles, most of us actually know somebody who's actually had a case of shingles, and about 1 in 3 Canadians will develop shingles in their lifetime. And in fact, as we get older, we know that our risk of developing a case of shingles will be upwards of 50%. So this is really common, and it's something that happens more commonly in older people as well. So what is shingles? So anybody who's actually had chickenpox is at risk of developing shingles, because shingles, or the herpes zoster, is an infection that's caused when the chickenpox virus is reactivated in our bodies. So it's a virus that lives in our nerves, and then it'll go dormant after a case of chickenpox, but it can be reawakened, if you will. And it often occurs when our immune systems are weakened. So the diagram down below kind of shares a little bit of the life cycle, the idea that you have that primary infection, the virus after that primary infection will stay dormant in the body, but it can be reactivated once or multiple times over our lifetimes. And because it lives in our nerves, for example, it tends to follow a nerve root presentation. So if you were to develop a case of shingles, here are some of the symptoms and complications, because shingles usually appears as a painful, localized blistering rash. The most common complications of shingles, of a case of shingles, is post-herpetic neuralgia, or PHN, where the pain can last longer and usually than 90 days, for example. And other complications from a case of shingles include vision loss, from the rash appearing around the eye, central nervous system infections, neuromuscular diseases, nerve palsies, and bacterial superinfections. So for some people, they'll say, oh, I just had a rash, it was irritating, it went away after about a week, and that was fine. But unfortunately, there is a good subset of people who will actually have these this post-herpetic neuralgia or some of these other complications as well. So it's why it's really good just to avoid having a case of shingles in the first place, or if one was to have it, to make sure that it's it's as minimal impactful as possible as well. So we know that the most important risk factor for developing shingles is age, and because our immune systems naturally weaken over time, and over 2/3 of shingles cases occur among adults who are aged older than 50 years overall. And so we also know that older adults have the highest rates of infection, complications, and hospitalizations as well. This is why we're particularly interested in talking about this as an institute, because we know this is something that predominantly affects older Canadians. And there's various factors that can contribute to a case of shingles. So some of the factors can be having a family history, being female or of Caucasian ethnicity. But those who have certain chronic health conditions, something we're more likely to be living with as we age, like diabetes or cardiovascular disease or COPD or renal disease or cancer, any of these sorts of things can actually increase our individual risk of having having a case of shingles. And one thing that we noted there was the idea of immunosuppression, basically mean having a condition or maybe taking medications that might suppress our immune system. And so on this next slide, this really speaks to some of the examples of conditions or situations that could be considered immunocompromising. So if people have a primary problem with their immune system, that can lead to an increased risk. If people have certain conditions, like HIV, for example, or certain types of cancer, for example, or people have had a transplant, these can lead to a weakened immune system as well. And then often in those situations, people might be on some immunosuppressive therapy. So medications or treatments, for example, like chemotherapy and other treatments that can also weaken our immune system. So all of these are examples. So that's why we tend to see this more often. It's not just getting older and age itself, but there's also a lot of things associated with being older that can lead to a higher risk. But this is also why these things can occur in younger adults too, people younger than 50 years of age. Vivien, I don't know from your practice as well, if there's anything else you want to say about any of the risk factors or individuals you see in your practice who get shingles.
Well, Samir, we often talk about personalized medicine. And I think one of the things we have to do is look at each individual as an individual. You've mentioned age as being a significant factor. That's absolutely true. But when we when we look at other risks, it can be in someone younger than age 50. And so someone, for example, with psoriasis who may be on a drug called Skyrizi, which is now a very popular drug for psoriasis, is at greater risk for shingles, even though they may be under the age of 50. We know as we get older, the risk goes up. Women are more at risk than men. And the older you are, the more at risk you are for post-herpetic neuralgia, that chronic pain. And that pain can last more than 90 days. Pain can last months to years. So I think we have to look at each person as an individual. Age is just the initial cutoff. Everybody 50 and over, let's pay attention to you. But we also want to look at younger people as well.
Excellent points. And again, it just reminds us that that's why we have to be personalized in our approach, because these issues that we've just raised on this slide and the previous one can happen in people younger than 50. And that's part of the reason it can put people younger than 50 at increased risk. And when we look at the direct healthcare costs of shingles and post-herpetic neuralgia, it's estimated to be about $68 million annually in Canada in terms of these costs to our healthcare system. So certainly this does add up. And this is not necessarily a condition that will lead you being admitted readily to a hospital, for example, but this translates into medications that people might have to take to try and manage some of the symptoms, for example, the increased visits to primary healthcare providers and others, for example. So this is where the costs start to add up, particularly in the case of shingles.
And also increased caregiving. One of the things about shingles, and if you do have pain after shingles and the side effects from all the pain drugs, is people can't live independently. They need caregiving at some level. And so we start to look at the indirect costs as well, because you start to lose your independence when you're in such pain. So shingles, yes, for some people it's just a rash, as you've mentioned, but it's a scary disease. It can make people really very unwell.
Yeah, and I think probably you can probably think of several patients. I can think of patients in my practice as well who, they just say, "Gosh, I wish I followed your advice and got that vaccine, for example, because had I done that, then I could have avoided kind of this
Yeah.
thing that really has impacted my quality of life, or, as you said, Vivian, kind of makes you dependent on other people."
Yeah, it may not be life ending. It's not a life ending disease, but it's a life altering disease. And living independently in the community is what everybody wants to do. And this can alter that, your ability.
Absolutely. So I mentioned vaccines because, we want to talk a little bit about that. The fact is, there is something that we can do to prevent shingles in the first place. So we know that vaccines are important because they can help us protect others. They also can help us, support ourselves, and that they're a safe option. And in particular, we know that our immunity will weaken as we age. That is why we recommend people, especially 50 and older, or adults who are younger and maybe more vulnerable to a case of shingles, to get a shingles vaccine. So again, the key is that we do have a good and effective shingles vaccine, and these are some of the reasons why vaccines can be important, not just for shingles, but for other vaccine preventable diseases as well. So the vaccine that is available in Canada, that has been approved in Canada since 2017, is called Shingrix. This is the only vaccine available in Canada against shingles now, and the vaccine itself is given in 2 doses. So usually, kind of between the 2 to 6 month mark, for example, that people would get a single dose, and then they would get that second dose as well. And how effective is the vaccine? Well, the good news, it's really, really effective. So again, if you are, so from the initial studies and also follow-up studies now, since that vaccine was introduced in 2017, we know that for people who are 50 years and older, for example, it's about 97% effective. For those who are 70 and older, it's about 91% effective. And against that complication called post-herpetic neuralgia, it's over 90% effective, again, in people who are 50 years and older. So again, it's really effective about preventing cases of shingles, and it's really effective against preventing especially that devastating symptom of post-herpetic neuralgia that can occur. And the good news is that people who've had a shingles, there's 2 doses of the shingles vaccine, 11 years on, it's still very, very effective. The effectiveness itself drops only to about 88% for those who are 50 years and older, kind of after about 11 years. So it's a pretty good vaccine that has quite long-lasting immunity right now as well.
And Samir, I think to put this in context, when we look at flu vaccine is about 50% effective. When we look at pneumonia vaccine, it's about 50, maybe 60% effective. So to have a vaccine that's in the 90% is really excellent. And that 11-year data that's showing that the vaccine is still in the high 80s at 11 years is very reassuring.
Absolutely. And this is also kind of, some people say, do I really need to get both doses, for example, or can I just get one? So we know that just getting even one dose can be effective, for example, and this kind of shows you what kind of the effectiveness dose with this is the blue line on the graph here is. But again, the reason why we give 2 doses is that second dose is, if you will, a booster, for example, and it gives you that long lasting effective immunity. That's why we say the effectiveness is much higher with 2 doses. And again, it has some good proven effectiveness for up to 11 years for those who get the 2 doses as well. And so NACI, which is our National Advisory Committee on Immunization, they have made some recommendations around the Shingrix or the shingles vaccine, if you will, and they recommend this should be offered to adults 50 years and older, including individuals who might have been previously vaccinated with another shingles vaccine, or even if you've experienced a previous episode of shingles. So we have to remind people that if you've had a previous episode of shingles, it means that you're actually probably at increased risk of experiencing another case of shingles. So even if you had a case of shingles, you're a very good candidate for a vaccine. And they basically say that you should consider it. You can consider it after a year. But again, talk to your healthcare provider. They might want to provide it earlier. And again, if you were previously vaccinated, there's an older version of a shingles vaccine. It was known as Zostavax, for example. Again, it was a pretty good vaccine, not as effective as this vaccine. So even if you had that previous vaccine, they recommend that you get vaccinated with Shingrix because, again, this will give you even more robust protection overall. Vivien, did you have anything else you want to say on this?
Well, Zostavax had been off the market since 2022. And so we know that no one's had it recently. And so you can forget about it if you've had it before because it did what it did when you had it, but it's not giving you long lasting immunity. And one of the things we know with Shingrix is because there's an adjuvant or irritant in the vaccine, your arm really does get sore, but that's really a good wake up call for your immune system. So we know that this vaccine works really well. So it doesn't matter if you've had shingles, it doesn't matter if you've had the previous vaccine, it doesn't matter if you're not sure. The bottom line is you should get immunized.
Absolutely. And so right now, there's current coverage available, but it's quite patchy across the country. So only Prince Edward Island currently covers Shingrix for all adults 50 years and older. So they follow the NACI statement, if you will. The Northwest Territories, Ontario, Quebec, and the Yukon, they provide coverage for certain older adult groups. Alberta and Quebec provide coverage for all or certain immunocompromised individuals. A few government initiatives provide coverage. But the Shingrix vaccine may also be covered by private insurance. So if you do have some form of private insurance, you can see if it is covered. But for those who don't have any access to insurance coverage or public coverage based on where they live, then there is an out-of-pocket cost, which is about $150 to $190 per dose. So really, this does end up creating care gaps across the country because when we actually take a look at what our coverage levels, we know that right now, only about 39% of adults 50 years and older have received at least one dose of the shingles vaccine. When we look at people who are 80 and older, it's about 59%. And that's because a number of the programs that exist with certain provinces that are providing public coverage are doing it for their older populations, 75 and 80 years or older as well. We also know that coverage varies across Canada from 25% in New Brunswick to 57% in the Northwest Territories for adults 50 years and older. And one of the reasons why we have such good coverage in the Northwest Territories is First Nations and Inuit Health have put it part of their formulary to make sure that Indigenous people can get vaccinated. And I understand that the Northwest Territories government has said we will offer non-Indigenous people the same coverage as well. So part of the reason why they have a really, really good uptake level there. But again, this really just shows you what variable government policies and public health programs can lead to, because certainly it's not a negligible cost for the vaccine. And that's why, as you'll hear a little bit more, what the NIA is doing and what Dr. Brown and I do is really trying to advocate that that this very effective vaccine is one that we can try and make available to all eligible Canadians. So when we look at some of the reasons why older adults are not receiving shingles vaccines, we know that it's a few reasons, right? We have a number of people who are 50 and older who have had noted a lack of necessity as the most common reason. So not thinking that they actually need it, or just that they're not informed enough around shingles and the idea that there is a shingles vaccine. But equally, we also know the cost of getting vaccinated has really impacted the uptake of the shingles and other routine adult vaccines. And I'm going to ask you, Vivien, like again in your primary care practice, I know that in my practice in geriatrics, I think a lot of my patients are just unaware that there's actually, like, they know what shingles is. They want to do what they can to prevent it, but they weren't even aware that a vaccine existed. So I find a lot of that in my practice. What do you see in your practice?
Well, I think that we talk about shingles a lot, and the public knows this disease. And so I'm working very hard to try and get people immunized. And when I talk about the cost of the vaccine, I also talk about the cost of not being vaccinated. Because for a younger population, if you get shingles, you're going to miss a couple of weeks of work. Even if you do go to work, you're not going to be able to concentrate. If you've got post-herpetic neuralgia and you're in a lot of pain, it really is a very disruptive disease, even if it doesn't land you up in hospital. So there's a cost to being vaccinated, but you're playing Russian roulette. There's a cost to not being vaccinated. And I sometimes frame it in terms of independence and immunization going together.
Perfect. Okay. And so again, we know that the most trusted source of information about vaccines among adults in Canada are their healthcare providers. And we know that 75% of non-immunized adults in Canada would likely get the shingles vaccine if recommended by their healthcare provider. So it's also something that we actively do to try and remind healthcare providers that while they're very busy dealing with so many different things, making sure that we bring up the issue of vaccines, as Vivien and I do in our practices, is why it's really important that we raise this, because I think it really makes sure that people can get the right information they need as well.
And Samir, there was a study done in Quebec by Marc Steban, his group, where doctors thought that the reason people weren't getting vaccinated was the cost. And when they asked patients why they weren't getting vaccinated, over 80% of patients said because it wasn't recommended. If someone comes into my practice and I don't talk about it and they walk out the door, they say to their partner, can't be that important. She didn't even mention it.
That's
So,
exactly.
we've got to be talking about this on a regular basis so that people get a chance to think about it and make the decision for themselves, because that recommendation is just so important.
Absolutely. And it's kind of like when it was, according to this slide, for example, like when it was the COVID pandemic, for example, and certainly we had COVID vaccines available. Certainly, I know every healthcare provider was encouraging their patients to get vaccinated. Our messaging was very clear. And so when people say, oh, well, if it's only 39% of old eligible Canadians have gotten shingles, they're probably vaccine hesitant. They probably don't want to get vaccinated. But often, as you were just saying, it might be the costs, and if people aren't even mentioning it or they're not even aware of it, there's a whole bunch of factors that play in. So we remind people that 95% of older Canadians reported getting at least 2 doses of their COVID-19 vaccines. So it's time for the uptake of other recommended vaccines to improve. And partly, as you were just saying, Dr. Brown, it really is about us as healthcare providers doing more work like this so that we can show that, yes, this is something that we think is really important, and certainly something that all healthcare providers should be emphasizing, especially when we have really good, effective vaccines available. So again, the other thing too is it's really helpful to remember, because sometimes it's kind of like, well, I've got a lot of things going on, and so can I actually get this vaccine? Can I take this vaccine with other vaccines? And the good news is you can. NACI has noted that the shingles vaccine may be given at the same time as other vaccines, and so certainly if you are, for example, it's cold and flu season, for example, and you're going in for your influenza vaccine or for your RSV vaccine or your COVID vaccine, you certainly can double up with those vaccines. You can also double up with a shingles vaccine. So it's not something where you have to get this at a very separate appointment at a different time. You can certainly get your shingles vaccine with another vaccine as well. And so we have to just really encourage, enable, and incentivize our healthcare providers to safely co-administer these vaccines and make it convenient for our older patients to stay up to date with their recommended vaccines. But I think, Vivien, I think you say the same thing that I do. If a patient of mine is getting that shingles vaccine, you mentioned the adjuvant, which, so I always say to my patients, yeah, if you get the shingles vaccine, you're more likely to have a rotten weekend ahead of you. So I just say, try not to get your vaccine, kind of the day before your granddaughter's wedding, for example, because some people, have a bit of a rough day or two, and then they're back to normal. Most people don't, but some people will. So, but again, it's one of the reasons why this vaccine is so effective, because it has that powerful adjuvant or booster in it. But Vivien, any other tips that you give when you're administering this, or co-administering it with something else?
So I do give multiple vaccines together. Like I'll give Shingrix with a flu vaccine, for example, very commonly. And I remind people that we give babies multiple vaccines at the same time. They get 8 different shots. It's often combined, but they get, 8 different vaccines at the same time as an infant at 2 months, 4 months, and 6 months. So when we're talking about these vaccines, I tell people your immune system reacting may give you that low grade fever, muscle aches and pains. You're home for a day or two. It's a Netflix weekend. I don't call it a rotten weekend. I call it a Netflix weekend.
I like
Stay
that.
home, watch TV, take it easy. And then, Samira, the odd person will call me and say, I didn't have any reaction. What's wrong with my immune system? Our immune systems are different. Not everybody has a reaction. Most people don't, as a matter of fact. But if you do, it's not serious. It's your immune system reacting, and that's not a bad thing.
Exactly. That's, as you said, right? Some of my patients will say, I didn't feel anything. And I'm like, oh gosh, do you even have an immune system, right? Because when, I jokingly, that's what I mean, because it's that aspect that, I always remind people that if you are reacting, it's showing that your body is responding, and is developing those crucial antibodies that you need. So a reaction is a good thing. And I'm going to now steal your terminology and not call it a rotten weekend, but a Netflix weekend. I like that a lot, actually. So this is how we learn from each other. There we go. So the NIA has put out a report called The Overlooked Issue of Shingles Infections in Older Canadians and How to Address It. And again, if you're really interested in learning a lot more about shingles, and some of these policy and broader issues around it, then this is a much more in-depth pamphlet that you can access. We also have produced a guide to vaccines for older Canadians. I think I have a slide coming up showing that as well. But that's certainly one that can give you just a nice summary of what you need to know about this, but also the other vaccines that are recommended for older Canadians. But the NIA has 8 specific recommendations in our overarching report, where we talk about the importance of promoting a life course vaccination schedule that includes older adults. So Vivien is a primary care provider who does cradle to grave, if we call it, care, so right from young babies all the way to older adults. And so really thinking about, we all need vaccinations throughout our life course. And we should remind ourselves that, you don't outgrow the need for vaccinations. We also talk about the importance of improving our surveillance of shingles cases across Canada, and its implications on Canadian healthcare systems, because I think a lot of this goes undetected or unnoted, and certainly understanding that helps us also appreciate the value of vaccinations, and the role it can play in terms of containing healthcare costs. We also talk about the importance of improving reporting and monitoring of shingles vaccination rates, because we don't have a national vaccine registry. And a lot of the data that we're showing you on rates of vaccination are what people say they have received through telephone surveys. We don't have a national registry where we can actually count exactly the number of doses that were given as well. So we need to do better. And we also recommend that we should be providing the shingles vaccination free of cost to all eligible Canadians aged 50 years and older. So what Prince Edward Island has done, we think that should be done across the country, so it's not such a patchwork, resulting in different levels of access to this vaccine as well. Also, we basically say that we should continue to adhere to Canada's current NACI statement for shingles vaccination. So NACI routinely puts out statements and recommendations, and we're certainly continuing to follow that guidance, but we think it's great guidance and something that we should. We need to make sure that we provide clinicians, the people like myself and Dr. Brown, the right education support they need so they can deliver vaccinations and remember to incorporate it as part of the work that they do, the regular work they do with their patients. We recommend the administration of the shingles vaccine in conjunction with other vaccines when it's appropriate to improve uptake and compliance. And again, you may have gathered from that earlier slide that every province and territory approaches its vaccination policies differently. We think there needs to be some better work done to harmonize our vaccine administration across and within Canada's provinces and territories as well. So this was the guide I was mentioning, a guide to vaccines for older Canadians. We've now translated into multiple different languages as well, and so it was just updated, and it was, and I believe they are now all up to all available on our website. So again, it talks about the shingles vaccines, but also it talks about COVID vaccines, influenza vaccines, the RSV, pneumococcal, tetanus, and diphtheria. So again, I think Vivien knows this. I think it's one of her favorite stats is that the Public Health Agency of Canada routinely asks Canadians, are you up to date on your vaccines? And usually upwards of almost 90% of Canadians say, yeah, I think I'm up to date on everything. And then when they actually go through, well, have you had all of these things? The real response is only about 3% of Canadians are regularly up to date. So again, if you're any of our members who are watching today, you can easily download this guide. You can look through, and it's a great thing to take to your primary care provider and say, hey, do I have all these? Am I up to date? Just to make sure that you are keeping up to date with these vaccines and how to get them as well. So with that, I'm going to suggest that we now just kind of go into our Q&A piece, and we have more than half an hour available to answer your questions. So just to remind folks to please put your questions and answers in the Q&A box that you see at the bottom of your screen. And then if you have any technical issues, you can look into the chat one. So Vivien, I'm gonna pepper some to you, and I will answer other ones as well. But the first question, I think you probably get this in your practice, is shingles contagious?
So that's a really good question because the answer is yes and no. The blisters that you get from shingles have varicella virus in those blisters. That's chickenpox virus. And what that means is if someone is exposed to those blisters touching you, for example, if they're susceptible to chickenpox, they can get chickenpox. So who would that be? A new baby that hasn't been immunized, or somebody that is severely immunosuppressed? So for example, if you're a grandmother and you've got shingles on your face and you're holding your grandchild on your shoulder, you can be giving chickenpox to that new baby. You don't give shingles to your partner. Herpes zoster is not what you'll give to your partner. So it's not contagious in the sense that you're not giving zoster to somebody, you're only giving varicella to somebody, and that somebody would not be immune to chickenpox. So that's not likely to be your partner in your age group.
And then building on that one is Marjorie asks us, now that Canadians are increasingly getting vaccinated against chickenpox, so that varicella vaccine, as those individuals age, do you expect the shingles will go away? As can an individual vaccinated for chickenpox develop shingles later in life?
Well, that's a really, really good question, and researchers are looking at that. When you're immunized for chickenpox, you have chickenpox antibodies. You have varicella antibodies. You don't have varicella virus in your system. However, it's 2 shots for chickenpox, and you may have had a mild case in between your first and second shot. So you may actually have virus in your system that you don't know about. So we don't know the answer to that yet because the age group that is immunized is only in their early 20s, and that's not the age group where we start to see a lot of shingles. So the jury is out. We think for the most part, we'll be seeing a lot less shingles in people who are immunized, but it's not a guarantee that they won't get shingles because they may have had a mild case of chickenpox between their first and second shots.
Yeah, and then Daria kind of asks in a related way, I had chickenpox in my childhood. Am I at higher risk for getting shingles later in life? And would the vaccine protect me from virus activation? And Daria shares that I'm 43, I'm Caucasian, and I'm female.
So that's exactly who should be immunized. You had chickenpox as a kid. That varicella virus is in your system. You're in your early 40s, so your immune system's still pretty good, and it's suppressing that virus from coming to the surface. But yes, eventually your immune system is going to get weaker with time, and you're the person that should be immunized because you do have that virus in your system. It's latent right now, or it's asleep right now. It's being suppressed, but it will come out with time later on. So yes, you should take the vaccine. And if you're generally healthy, even being female, even being Caucasian, you generally wait until you're around 50. If you have underlying diseases such as lupus or psoriasis, diabetes, other diseases that affect your immune system, you may want to take the vaccine earlier than age 50.
Yeah, and it's also a great point, Vivien, because as this is, Daria there was just saying, like, I had chicken pox as a kid, and then there'll be some people who say, I don't know if I ever had it, for example, right? And so sometimes you might have had such a mild case, for example, you weren't even aware that you had it, for example, and especially if you had it, as you were just mentioning, as a baby, for example, maybe people thought it was just a rash or something, you're a bit irritable for a while. So sometimes people may have had a mild case. And so just if you're not sure if you ever had it, for sure, then likely is that you probably did have it. And I'd still recommend that one gets protection, especially I think, Vivien, when you're saying even if you did get the varicella vaccination right now, the jury's out. We don't know that for sure that you are going to be fully protected. But I don't know if you have any other thoughts, because I certainly do have some of my 80-year-old patients who might say, I don't think I ever got chickenpox as a kid. And I'm like, let's not find out.
Yeah, it's so contagious, and it was so common in that age group, that NACI says we shouldn't be doing blood tests to prove whether someone's had chickenpox or not. We should just immunize. And if by chance you're immunizing someone that didn't need immunization, there's no harm done. So in general, we're not doing titers, we're not doing blood tests to check for varicella. What we're doing is just immunizing.
Right. So we have Canny saying, I'm unvaxxed and had shingles several times. How long after my last attack do I have to wait before I can have the shingles vaccine? It's a great
So
question.
it is a great question. And the Canadian guidelines suggest 1 year. That's expert opinion, not based on data. The American guideline is quite different. The American guideline says as soon as those lesions are healed, as soon as the blisters are gone, take the vaccine. Because especially if you've had shingles more than once, you've shown that you're susceptible. And so you're more likely to get it again. So you can take it as late as a year after the episode, but the Americans, the ACIP guidelines, ACIP advises the CDC on immunization. They say as quickly as 2 months after the episode.
Yeah, and it's one of those sorts of things where, sometimes you can develop some immunity after you've had an infection, for example. But, we always talk about incomplete immunity. Various people might actually, have a very robust immune response. Others won't necessarily. So that's why, as you said, right, the American guidance is probably saying, after you've recovered, for example, you may have some level of temporary immunity, but we don't know how good it will be. Hence, you might as well not wait for a year and potentially another infection, especially if you're immunocompromised. You might as well get that good protection as soon as possible.
Yeah.
Perfect. Okay. Kind of related to that, there's just some questions related to cases of shingles in general and saying, how long does a case of shingles last? So, Vivien, I come into your practice and say, I've got this rash on my chest here, and you're like, that's shingles. And I'm like, how long, doc? How long is this going
Yeah.
to last?
So the rash can last 14 to 21 days average. And when we put you on an antiviral like valcyclovir or famciclovir, it helps the skin heal up faster, but it doesn't change any nerve damage. So even if the rash has healed, you still can have nerve damage for weeks to months to years after shingles. So the rash healing about 21 days, but that nerve pain is variable, depends on the patient.
Perfect. Okay. Um, yeah, and we have some different questions here about and okay, and related to that, actually, just the new question just popped in was, what should I do if I think I have shingles?
So if you think you have shingles, I would start on an antiviral because there's no harm. And the sooner you start it, the better it's going to work. The antivirals in Ontario, at least, if you're over 65, is paid for by the government. And you would start on the drug immediately within the first 72 hours of the time when you think you have shingles. You're on it only for 7 days. It's going to stop that virus from multiplying. It's going to help the rash heal. What it doesn't do is it doesn't prevent nerve damage. So start the antivirals by all means. And even if you're not 100% sure, start them because they're not going to do you any harm. But it's not going to help with nerve pain.
Yeah, and one of our attendees was asking, are there any other resources that can be shared for those living with post-herpetic neuralgia or that nerve pain? I don't know any resources off the top of my head. But Vivien, do you know of any resources?
No, but there is a chronic pain, a number of people that deal with chronic pain. I think for the individual, you would speak to your physician to see if you can get referred to someone who is a chronic pain specialist, because different people deal with chronic pain in different ways. And there are chronic pain guidelines for doctors in Canada as to how to treat chronic post-herpetic neuralgia. It's difficult. Usually you're on more than 2 to 3 drugs at a time, and those drugs all have side effects and impact, but the pain can be excruciating.
Absolutely. Just changing tact a little bit. Some people are asking about kind of eligibility for vaccines, for example. So Lisa is saying, can post-transplant clients, in this case, she says post-lung transplant clients get the vaccine? And I can say absolutely. So basically anybody who has had a previous transplant is most likely going to be, or most certainly going to be on immunosuppressive medications. And so these are great candidates, or these are folks who are at high risk of getting shingles or other infections as well. So absolutely, these are folks that we would recommend getting the vaccine. And certainly transplant specialists, for example, would be able to help review the vaccines that people should consider getting as well.
And Samir, this is not a live virus vaccine, so it's a very safe vaccine. We were cautious with Zostavax if people had herpes ophthalmicus, if you had shingles in your eye, and there was a concern about whether the vaccine could actually make that worse. We don't have that concern with this vaccine. It's not a live virus vaccine, so
Yeah.
just about anybody can get this vaccine.
Yeah, and the old vaccine was a live virus vaccine,
That's right.
but the new one is not a live virus vaccine. So that's where our attendee there might have been saying, well, that might have been a reason why I was told not to get something before, but certainly it has that. Someone has just said, I had shingles at age 48. This is Shoshana said, should I get the shingles vaccine? I just turned 50.
Yep. Very
Exactly.
clear. You're at risk for another episode. You've already shown that your immune system is not as robust. It allowed you to get shingles the first time. And now your age related immunity is changing. So, yes, I would absolutely get immunized.
Yeah, and someone was saying here, okay, so I get the Shingrix vaccine. Should one be when should someone be considered immune, for example? So they said, for example, I understand after getting my COVID-19 vaccine, usually after 2 weeks, I have, my best level of immunity. But this is a two-parter vaccine as well. So I think there's some immunity that you get within a week or two of getting your first dose, but it's that more robust, kind of real good coverage, that 97% effectiveness that I think you would get once you've completed your second dose. But Vivien, anything else you'd say on
Well,
that?
the second dose can be given within 2 to 6 months of the first dose. I try and bring people back at 2 months. I don't want to wait all that time and take the chance of getting another episode. So I think the sooner you get the second dose, the better it is. And the study and guidelines suggest that by 2 months, you can take your second dose. If you're immune suppressed and we're giving it to a younger person, you can actually take the second dose as early as 4 weeks after the first dose, because we don't want you to be walking around without good immunity. So, yes, get your first dose and book your second dose for 2 to 3 months. Don't wait 6 to 12 months. There's no benefit. The earlier you take it, the more likely you are going to have that robust response.
Absolutely. And so we've had a few questions about the specific, the vaccine itself. So they said, so is Shingrix, the two-dose form, a good for life protection, or should it be repeated? Because I understand that the zoster virus doesn't mutate as fast or efficiently as COVID or flu viruses. So, right now we're just saying we know that it's providing pretty good protection, even up to 11 years if you've received 2 doses. So right now we're not recommending that people get a repeat vaccination at this point, and they might have lifetime coverage with it, but eventually we might say there's a point, because I think, as you mentioned too, many vaccines, we generally think a really good vaccine is something that's at least 50% protective. For example, like influenza, this is 97% effective if you get your 2 doses, kind of, at the early stages, and it lasts about 87% effectiveness, for people 50 and older, up to 11 years onwards. So right now, I know that we're not recommending repeated doses. But Vivien, anything else you want to say about that?
Well, the data you showed shows that we've got good data for 11 years, but the experts in modeling who model out what is expected from a drug or expected from a vaccine have said that the modeling looks at 20 to 25 years of good response. So we're not looking at booster doses in any time in the near future. And if in 20 years we have to alter our plan, what we will do that is based on data and based on what's available at that time. So right now, no booster doses. We've got good data for 11 years, and we've got modeling data out to 20 years.
Yeah, absolutely. And I think you were mentioning having psoriasis and treating people with Skyrizi. And so I think the answer is going to be absolutely yes to this, but they said someone just erased the question there. I can do that myself, thank you. But they were saying my husband is 50 years of age. They have psoriasis, they're on Skyrizi. Should they get the vaccine? And I'm saying, absolutely, yes. And
Yes.
Vivien, there we go.
Huge yes, because you've got a combination. You've got an immune suppressive disease, an immune modulating disease like psoriasis, and then you're adding in an immune suppressive drug like Skyrizi. So you've got both the disease as well as the drug. So yes, these are the people who are immune suppressed that we are advising get immunized. Chronic colitis, bowel disease, arthritis, now not osteoarthritis, but inflammatory arthritis, such as psoriatic arthritis or rheumatoid arthritis. We're looking at lupus as a disease. MS is an immune modulating disease. So diseases that affect your immune system, and then the drugs that we use for those diseases put you at greater risk. So yes, the psoriasis Skyrizi was just an example, but absolutely yes.
Absolutely. And so a few other ones that are related to vaccination here. So someone said, for example, and this is a really good question, I'm glad they've asked it, because there are the one dosers out there. So they said, I think they're referring to, they said, I got my first dose 4 years ago. How many doses should I take now? So I'm going to reframe this. I think this is what they're saying is, it's a 2-dose vaccine, but they may have only gotten 1 dose. And let's just say, 12 months passed, they just didn't get around to the 2 to 6 months, their booster, for example, or in this case, this person's like, I got the first dose and gosh, it's 4 years and I forgot to get my second dose. So do they start over, or do you just give a second dose? What do you do in these cases, Vivien?
So the general guideline is that you never start over a multi-dose series. So if it's hepatitis A, hepatitis B, HPV, Shingrix, you just give the next dose when you're able to see that patient. Now, you're not going to get that 97% that the patients in the study got. You're not going to get that level of efficacy because you've taken the doses off. The timing has not been correct, but you are going to get reasonably good efficacy. We only start over completely in a bone marrow transplant patient where we've wiped out their immunity. In everybody else, you just pick up where you've left off. So no, you would not get 2 doses. You just go back and get your second dose and get it as soon as you can.
Perfect. I'm going to remind folks that if you have any additional questions you'd like to ask Dr. Brown or myself, again, you can put those in the Q&A section of our chat. We still have a few more to go through, but just inviting, if anybody's kind of, I'm not sure if I should ask it, go ahead and ask it. And we're happy to get through to that question. Again, related to this whole piece is if an individual is vaccinated with Zostavax, so this is the older version of the shingles vaccine that's now no longer available in Canada after 2022. They said if an individual was vaccinated with that in the past, do you recommend they receive Shingrix? And I think we've already said absolutely yes.
Yeah.
They should get the 2 doses of the Shingrix vaccine.
Yeah, they're two separate vaccines. That vaccine is worn off, and yes, you should be immunized.
Perfect. Okay. Um, Yeah, and so another one is thinking about kind of we mentioned kind of people who have psoriasis and they might be on immunosuppressive medication, or people who are have been transplanted and they're on that. And a person was saying, "Hey, if I'm taking prednisone, is there a certain amount of prednisone that is considered immunosuppressive?" Because certainly there are a lot of people who might even be taking a small dose of 5 milligrams a day, to kind of keep some conditions at bay. Other people are on much higher doses, on a chronic basis. I think any amount is immunosuppressive, but Vivien, do you have a specific number that you work with?
So that's a very good question. And, when we look at bone health, a certain amount of prednisone over 3 months puts your bones at risk. I think that we start to worry if you're getting more than 20 milligrams on a regular basis. But even if you're getting a lower dose, even if you're getting 7.5 milligrams, if it's consistent over 3 months, it does affect your immune system. So for that, I would talk to your physician about whether the prednisone is significant or not, and how much you're actually getting. Sometimes with asthma, for example, you may get boosts of prednisone where every 3 months you're taking a high dose, but only for about 7 to 10 days. That adds up over the time. And that way, I think you have to discuss it with your own doctor in terms of the dose you're taking and whether that's affecting you. I worry about anything more than 5 milligrams on a regular basis.
Yeah, exactly. And I think it's also, I think you pointed that out, right? If you're getting if you're getting prednisone on an ongoing basis, and we usually say 3 months or more, as I think you just mentioned, Vivien, is that actually puts your bone health at increased risk as well. So you might have an increased risk of osteoporosis, and that's something, again, that there are things you can do to prevent against that. But also, you might, while people think about the steroids and the prednisone, there may be another medication, immunosuppressive medication you might be on as well, because there might be the prednisone and there might be something else. And then just having the condition itself might also put you at increased risk. So these are really good questions. But again, this is why it's great to chat with your specialist or your primary care provider, so they can let you know whether you'd be a good candidate for this. But generally, if you're 50 and older, absolutely. If you're younger and you're not sure, then good to ask these questions to your treating provider as well. So related to that, we have well, actually kind of relates to this one because it's talking about bone health. And so I think they're asking about vitamin D, and they say, can vitamin D enhance the immune system? And if so, what is the recommended dosage? So I know that I don't necessarily ask my patients to take vitamin D for immune system enhancement. I certainly do recommend that, especially in Canada, that our older patients are taking vitamin D to protect their bone health in general. And we generally recommend about 1,000 international units of vitamin D every day, maybe more if you're found to be deficient of vitamin D. But Vivien, anything else that you'd say if someone asks about vitamin D to boost one's immune system?
So there was research that looked at people who developed COVID. And if you developed COVID and you had low vitamin D levels, you actually did worse than if your vitamin D levels were normal. So I don't know that vitamin D will enhance your immune system, but low vitamin D is a risk to your immune system. So I would say that 1,000 to 2,000 international units per day for everybody over the age of 50 is reasonable. That's going to help your bones and it's going to protect your immune system. But they are researching this area. They're researching vitamin D as being a bit of a magic vitamin, affecting different things, not just bone, but also the immune system. So I err on the side of taking it.
Yeah, exactly. And again, 1,000 a day reasonable unless you're shown to have a vitamin D deficiency, then we might recommend, a higher level until you get your levels to a normal amount. And to your point, Vivian, with that study, again, I'm not familiar with it, but sometimes if you have a deficiency of vitamin D, it might also speak to your general nutritional status as well, right? You might have other low vitamin levels and you may not have been getting a good level of nutrition, which can weaken your immune system as
Right.
well. So it's always important. I know there's a lot of proponents out there for the magic of vitamin D. I think everybody, generally should be taking some, from a bone health perspective for sure. But I don't necessarily recommend it on the basis of boosting one's immune system until we have a
No,
little
I
bit.
mean, they also did some studies with vitamin D and colon cancer. Like they're looking at vitamin D in lots of different ways. The bottom line is we know that it helps for bone health, and having normal levels is good for you. Whether or not it's going to give you extra protection for colon cancer or your immune system or other things, we don't really know yet, but we know that low levels are not healthy.
Yeah. So we have another question from Lisa here says, is there an age cutoff where the shingle shot is not recommended? She says that my mother-in-law, who's 83, says she was told she didn't need it. She has lupus and a history of colorectal cancer. I think we would say she sounds like the perfect candidate for it, especially with her age and with some of her past comorbidities. But Vivien, anything else you want to say on that?
Even if someone's in long-term care, even if they're bedridden, the pain of shingles is terrible. So I don't think there's anybody that's not really a candidate to get immunized. Unless they're palliative and looking at 1 to 2 weeks, I don't think there's a reason not to immunize someone, because shingles is a disease that's common with aging, causes severe pain, and really affects quality of life. So even if someone's bedridden, even if they're in long-term care, I do think everyone should be immunized for shingles. It's a terrible disease.
Absolutely. And then speaking of long-term care, someone just wrote, if a resident is in a long-term care home with shingles and they have a roommate and we're unaware if the roommate is immune to chickenpox, can we give them Shingrix and so on? So again, I think it's one of those sorts of things where if someone is not aware of their immune status, they should be offered a shingles vaccine. And because again, just by being in an environment where one can get a variety of viruses more readily. But in this case, it's helpful to make sure that everyone has the same level of protection as well. Okay, and then someone says I have an IgA deficiency. Do I still get the shingles vaccine? I think again, generally, if you have some sort of immune deficiency, best to talk to your healthcare provider. Again, to see if you would be eligible. But I would suspect, again, if you're 50 and older, you should probably be getting it. And if you have some sort of immune condition, you probably have an increased risk of shingles as well.
And generally, an IgA deficiency is going to give you a greater risk for like superficial mucosal lesions, infections such as viruses that cause colds and flu and that kind of thing, because the IgA is not in your nasal passages and protecting you the way it should. Um, Chickenpox and varicella zoster is a completely different kind of disease. It's coming from the dorsal root ganglia. It's coming from that latent virus, and it would be affecting IgG and IgM, not IgA. So I think it would be important to get immunized, but you should speak to your own doctor, as Dr. Sinha suggested.
Yeah. And someone said after having shingles before I was the age 50, should we be getting the shingles vaccines? Absolutely. It just shows that you've had a case, you're at a higher risk, especially after you're 50 years of age. So we've already answered that one. So again, and we have to wrap up. But Meryl, you've had you've given us a question where you have multiple thoughts about your complicated health history. But it sounds like to me that you'd be a good candidate for the shingles vaccine. But this is where I'm sure you have a good healthcare team, that has worked with you around your cancer diagnosis and your transplant as well. I'm sure they would be able to give you really clear information on your eligibility and your candidacy for a vaccine. But to me, in general, it sounds like you would benefit. But I would certainly talk to them as well. So with that, we have answered, Vivien, a record 22 questions, but these were 22 excellent questions. And we want to really just say again, thank you to everyone for joining us today. We'll just make sure that our full slide is there. So this is, again, a big thank you. I want to say, first of all, thank you to Dr. Vivien Brown. She's an excellent co-pilot, a phenomenal family physician, and one who likes to use her voice to educate other folks on supporting their health and well-being. Not only are patients lucky, but we're all lucky to get her wisdom, and it's great to have a fellow clinician to speak about something that we're both very passionate about. So thank you to all of you for tuning in today, for asking your questions. You can follow us on social media. You can get our newsletter as well. And this presentation is being recorded, and so you can certainly watch it again if you miss some of the answers to the questions that were discussed today. So thank you very much again. And again, Dr. Brown, thank you for giving us your time today.
Thank you. Thank you to everybody. I think the National Institute of Aging is doing such important work. Thank you, Samir. Pleasure to work with you. Bye now.
Bye.